Okay, great. Welcome, everyone. Thank you so much for joining to listen to our experts about strabismus surgery RUC valuation. Thank you all for attending. This is certainly an emotional and difficult topic for all of us, but we hope to shed some light on the process and our next steps to answer your questions about this. So I'd like to introduce our speakers. First, we have Dr. Kayla Amodio. She is a director of health policy at the American Academy of Ophthalmology. We have Dr. David Glasser. He's the AAO Secretary for Federal Affairs, and our own Michael Repka, pediatric ophthalmologist and the Academy's medical director for health policy. So I'll kick it off to you guys, and we'll start with our slide presentation, and then we'll be open for Q&As because we're anticipating a lot of questions, and we hope to answer those questions here. So thanks so much.
Okay, thanks, Christy, and thanks for everyone for attending. I do want to point out that this is not our first discussion of this issue. There is a slide deck available for meeting registrants in the AAPOS annual meeting, and Christy might make that available behind the firewall for all APOS members if it hasn't been done. The content here doesn't vary very much, except it's now in the glow of the proposed notice of rulemaking, which we weren't in before. David Glasser is on his role as Secretary for Federal Affairs, but also because he's our RUC advisor, he's the physician charged with actually making the arguments for valuation. He's not a voter, nor am I a voter, nor ever will we be voters in this process. And Kayla Amadeo is our Academy director who basically manages the process for the Academy, although this process she inherited because we started it a long time ago and have successfully deferred it for a number of years. So why are we in this? And most of you guys know, which reminds me, please use the Q&A function rather than the chat function. It's simply easier for the panel to manage the questions and promote questions than the chat function, which is nice as well. So we do this because the Congress passed a law that said physicians are supposed to be paid relatively to each other and not on historic or customary charges as was been done before. And Medicare implemented the RBRVS system for the fee schedule starting January 1, 1992. And it slowly became the rule of the land. Every other payer started to utilize the Medicare RBRVS as the basis for their services. Now, they almost always paid a multiple, typically more than Medicare, occasionally less than Medicare. And it's supposed to be created by a standardized system. And the result of 25 years of that standardized system are some of the things that you're seeing in tonight's presentation. So the current strabismus surgery values come from the late 1980s based on Harvard resource-based estimates. They were basically the first times, which were the how long it took to do the service and the work values that were placed in 1992. Since 1992, the SHOW values have been slowly replaced by the AMA's Relative Update Committee, which works with CMS. In the instance of strabismus surgery, in 2018, CMS and the RUC recognized that there was a problem in how our strabismus surgery add-on codes were linked to postoperative visits. And in fact, they weren't supposed to have postoperative visits under the rules. They were also based, of course, on the original valuation. We tried through a series of letters and end runs to defer the resurvey, which we ultimately were able to get deferred until 2018 when they said we needed to go forward. By the time everything moved forward, the surveys were performed in early 2020, and they're leading to the revised values for the 2022 fee schedule. And unlike everybody else in ophthalmology, where the family is a handful of codes, in strabismus surgery, it was the entire 11 code set that came into play. And that turns out to have been a big disadvantage for us because all of the changes occur at one time. And that just doesn't happen pretty much anywhere else. So the timeline on conducting this survey, we began to educate on the survey. Actually, I should say we informed the board a year before that this was coming up, the board of APOS. Now, there wasn't anything they could do except say good luck on slowing it down. And we began at their request to educate the survey methodology with our membership. And so there were a series of webinars and questions and mailings. We were due to have a in-person presentation at the Austin meeting, which got canceled. That was converted to a webinar, which about 100 people did get on. And then we had that available to view, and I don't know how many views there were. Surveys were conducted during the heat of the COVID in April and May of 2020. And frankly, an extraordinary number of surveys for low volume surgeries were completed, far exceeding anything we would have estimated. The analysis of the survey results, however, was affected. During the period of time when the survey was out, a set of work values for the codes was placed on the APOS listserv. They are publicly available, but the RUC and CMS do not like any evidence of tainting of the survey with physician work values. In both halves of our data, they are very robust, and although the times were slightly longer in the second half, they don't turn out to have made a difference, although there's been a great deal of concern about them. We had to take these two sets of data, first to preliminary RUC meetings and then ultimately to the RUC itself, presenting both sets, and the RUC said, no, we're going to go with the untainted first version. Whether you think it's tainted or not, that's what we're going to do. We presented data along with the RUC advisor for the American Academy of Pediatrics. RUC sent its recommendations to CMS for consideration, and the valuations that were proposed by the RUC were accepted by CMS and published last month. They still are open for comment, and that's partly why Christy has sent out requests for you to comment to the Federal Register, why the APOS is going to be commenting, but it also puts our comments from the AAO and the AAP in a slightly different light. And we knew all along this is what was going to happen. Implementation of these new values will be in the physician fee schedule January 1 for Medicare. For commercial insurers and Medicaid programs, they will follow their own schedule if they accept them at all. So I'm going to turn over to David what was surveyed in the RUC survey instrument. So David.
Thanks, Michael. I think that was a pretty good history of what happened. You know, we've been, as Michael said, we've been trying to kick this can down the road since 2018 because we knew since the codes hadn't been valued in 30 years, and they're all based on those Harvard values, we knew it was going to be bad. In reality, we've actually been kicking the can down the road since 1998. That's when the post-op visit associated with the add-on codes was first flagged. And as long ago as 1998, there was some adjustment to the add-on code values, but it wasn't up to RUC snuff. So the RUC looked at the codes and said, you've got to revalue them. So we're kind of forced to do that. The other option is to say, no, we're not going to value them. And then the RUC or CMS gets to value them with no input from us. So we sent out the survey instrument. And for those of you who haven't seen it or haven't done a RUC survey, and no pediatric ophthalmologist had, I think, done a RUC survey, or very few had prior to this. They ask very detailed questions about how many minutes you spend, in pre-op, during the actual skin-to-skin part of the surgery, during the prep, the scrub, the dress, the weight, and then how much time you spend post-op and how many post-op visits you do. And they also ask for a magnitude estimation of work. So a guesstimate of, how much work, how many work RVUs do you think this procedure is worth compared to a variety of other ophthalmology codes that you might be familiar with, even if you don't currently do them. So we get all of that data and we have to put it together in a package that the RUC will accept and vote on for a work value. We have to get 2/3 of the RUC to accept it. So one of the issues we had early on was, what about this reveal of what the current work values of the codes were? That's publicly available knowledge. It shouldn't have influenced anybody, but the RUC wasn't buying it. So it was clear they weren't going to let us use the full data set. When we get into the nitty-gritty, I'll show you that it wouldn't have made a difference, even though there were a few more minutes for some of the codes. The times went down significantly, regardless of which data set we use. The other things that we value are the practice expense portion, which is a little more formulaic. There's not a lot of practice expense with a procedure done in a facility because, most of the staff time is, making the appointments and doing the scheduling. And then there's practice expense associated with the post-op visits. But there's not a lot of practice expense associated with doing the procedure itself. And then there's the professional liability component, which is basically a one-size-fits-all for the entire specialty. We have to package the data in a way that the work value of the code fits not only with all the other codes in the universe outside of ophthalmology, but also relative to other codes within ophthalmology and relative to each other in the family, which was a challenge with 11 codes that all had to sort of line up in a row. So we'll go to the next slide, which is a big, complicated slide, which shows what actually happened on the survey and with the work values for all 11 codes in one big table. So these are the work values. They're not the actual total RVUs on which the allowables are based. This is the physician work value. And the first 3 columns after the procedures are the ISTs and the change. IST stands for intra-service time. So that's the skin-to-skin time from when you sit down and start cutting to when you stand up from the table. And you can see that they went down for almost all of the codes really quite significantly. And we had a very robust survey. And, we had 50 or so people that responded before the reveal. And we had, was it 200, over 200 that responded in toto. And, that 25 minutes you see for the one horizontal muscle, that was the 50 or 60 people who responded before the pause. The median time for everyone was 30 minutes. So it was 5 minutes more. For the one vertical muscle, instead of 26 minutes, it would have been 30 minutes. So, that's an increase. But when it comes down to actually how we have to value the codes and match them to other codes in the database with similar times, even if we bumped them up to 30 minutes, we still would have had to crosswalk to codes with that 5.93 WRVUs. And that's what the actual work value, what the actual work value was passed by the RUC. So, and you can see in those last 3 columns, the old work values, the new work values, and then the percent change. So, for the most commonly performed procedures, we had 24% and 33% decreases and the work values. And for some of the add-on codes, the decreases were in the 60% range. So really devastating drops. During the negotiations with the RUC, people wonder, well, why don't you just say, we're not playing this game. It just isn't going to work for us. And the answer on the micro scale within the RUC is, if you do that, then you get taken to something called facilitation, where a subgroup of 6 or 8 RUC members look at the survey results and look at the data in the database of all the different codes, and they come up with their own value. And then they present that. And, we can either go along with it or not go along with it. If we still don't go along with it, then CMS just gets to decide. So the idea is to try to get the best number you can, because CMS tends to be much less generous. We go to the next slide, look at something I mentioned already, that the RUC votes on the values and makes recommendations to CMS. The work RVUs are based on the time and the intensity of work on the date of the service and post-op visits. And they have to fit in relative to other procedures. And we'll go into that in a little bit more detail with some comparisons. The practice expense is based on clinical staff time, equipment costs, and time used in supplies. And as I mentioned before, it's a little more cut and dried. There's less subjectivity to that. And then the professional liability. And you add all that up, and you multiply it by the conversion factor to get the actual allowable. So if we go to the next slide, we'll take a look at some aspects of relativity. This is supposed to be a resource-based relative value system. And I picked 67312, which is actually one of the codes that did a little bit better in the valuation. There are 2 ways that the RUC will value a code, will try to value a code. One is to do a crosswalk to other codes that have the same intra-service times and total times and number of post-op visits, and say that if the times are the same, the value should be the same. And ophthalmology usually does poorly when that happens. And that is what happened to the single muscle codes. We do poorly because our work tends to be more intense than that of most other specialties, and we see bigger drops. For all of the other codes, except those 1 muscle codes, we were able to get values based on that magnitude estimation of work that people say, we think, this code is worth XYZ RVUs. And actually, if we looked at the data from before the pause versus the full data set, most of the base codes, the 3 base codes that were valued on the magnitude estimation of work, did better with the people who answered first than with the whole data set. In any case, if we start looking in comparison to other procedures, this table shows you the intra-service time, the total time, and then the work RVUs of a number of different ophthalmic codes. So you see the 2 horizontal muscles, have less time than the other codes on this list, both in terms of intra-service time, which gets the greatest value per minute, also has less total time than any of the other codes, yet it came out with a higher work value. So we were able to argue that these were intense codes. They're babies. There's a significant risk to their long-term visual health. And, you're working and putting sutures, less than 0.5 millimeter from the retina. So even though these are considered extraocular procedures, which usually get lower values per minute, they ended up getting higher values per minute than a lot of intraocular procedures. Now, if we did this comparison with 67311, it wouldn't look so good. It would fall closer in line with these intra and extraocular procedures. If we go to the next slide, and we can compare 67312 to procedures in other specialties. So the RUC, really likes to see relativity, not just within the specialty, but from one specialty to another. And you can see the two horizontal muscles compared to a sinus procedure, pelvic abscess, an infant anal hernia, a young child with an umbilical hernia, and an ectopic pregnancy. And again, the times for the two horizontal muscles are lower, but the value is much higher. So the implication is these codes are more intense and complex. Where we failed was being able to get that magnitude estimation of work value for 67311 and 67314. I think that's the other single vertical muscle. And we tried, but we couldn't. And we couldn't because it would have put those single muscle codes valued almost as much as the two muscle codes. And the RUC just wouldn't buy it given the difference in intraservice times and the fact that you're doing kind of twice as much work. So we got stuck with doing a crosswalk, and that's why those codes got hit so badly. And it was really unfortunate because those are the two codes that have the greatest volume. The next slide shows really what the bottom line is. So we've been talking about work values, and of course it's work value plus practice expense plus PLI. And the blue columns on the left show what the allowables were in 2021. The three columns in the middle, the orange ones, show what the 2022 allowables would be if the full hit came all in 1 year. And then the green on the right shows what the allowables would be based on what CMS has put in their proposed rule, where they limit the maximum cut in any year to 19%. So all of the codes that had 22% cuts would get hit with a 19% cut in 2022, and the other 3% would come in 2023. So that's what's in the proposed rule. And we have, I think Michael alluded to, we have to support the RUC recommendations. That doesn't mean APOS has to, and we're happy to work with APOS and AAP to formulate arguments to do something different than what the RUC recommended. But because we have to maintain our credibility with the RUC for all codes, we can't say we agreed with this back during the RUC meeting and now we don't agree with it. So we fight very hard when CMS cuts things further than the RUC, but we tend to accept CMS recommendations when they agree with the RUC. In this case, I think we're going to make some recommendations that CMS departs from their usual and do a much more gradual phasing. And there are a number of other things we've argued as well, which we can get into. The next slide, I think, takes us into the realm of adding insult to injury. And here we see that, we've got the conversion factor set to go down at least 3.75% in 2022. It was supposed to go down that amount in 2021. Congress acted and boosted it, but that's expiring at the end of the year. There are other cuts that could add up to close to 10% cut to the conversion factor on top of all this. So I'm going to turn it back to Michael to sort of talk a little bit more about the bigger picture, and then we can start fielding some questions.
Yeah, thanks, David. I was going to comment that part of the reason for this conversion factor devaluation in 2021, the year we're in, is the upvaluing of some of the E&M codes, which is a place where many ophthalmologists have found a place to move at least some of their services to. And then with respect to some of the other arguments that can be made, Christy has already, I believe, written and submitted that letter to CMS and is certainly helping with ideas for other simple impact statements that go on to the CMS website. And that's the history of conversion factors. And when we look at the dollar values that Medicare creates, the first thing to remember is that Medicare never intended to pay cost. That wasn't part of their rule set. They don't get enough money on the pro fee side to actually pay physician costs. And I never forget the medical director at CMS telling me, we can't afford to pay you cost, and the conversion factor simply illustrates that. This is the history of the conversion factor. That's the multiplier times the value units that started at $30 or just about $31 back in 1992. And lo and behold, it's not much higher 30 years later at just under $34. And it's a reason that you could say that professional fee side of the equation has not kept up anywhere near what the facility side is. If you look at Medicare physician payments over the last 20 years versus the cost of living, we're off 24%. So the conversion factor sets the final table. As I said, we were going to entertain questions and discussion. And so I'm going to at least begin with. So Eric asks, does the practice expense calculation, David, account for overhead incurred while we are in the OR for rent, staff benefits, insurance? To what degree does practice expense affect the final value determined by the RUC? So Kayla, let me ask you to do the last question. So how does the practice expense, what kind of percentage does it affect in our codes? All right, maybe I'll.
Well, I mean, that changes based on the service. So I would have to pull it up for Strabismus.
Well, but for surgery
it's
codes, it's usually less than it is for E&M codes, for instance.
Absolutely. It's a, I don't want to say fraction, but substantially less.
And say for an
OCT,
OCT, it's almost all practice expense and very little pro fee.
So in addition to that, there's direct and indirect practice expense. So the RUC will make a recommendation for direct practice expense. So staff time, supplies, the amount of time that the equipment in the room is used. And then CMS has a complicated formula to determine indirect practice expense, which is the rent, the utilities, and all of that. So for surgical codes like, cataract and strabismus, the practice expense RVUs that the RUC sends over are often in the 40 to 45% range of the total RVUs. Whereas with a testing code where there's only a few minutes of physician time and most of the time is spent by the staff, acquiring the images and all of that, the practice expense may be 70, 80% or greater of the total RVUs that get sent over to CMS.
And David, one of the questions that people always ask, and surgeons in particular, is this problem of the OR both waiting for turnover, which is, we would say, the example, as everyone knows, that's always raised, whether it's by ophthalmology or by thoracic surgery, is cataract surgery has like no turnover. And so we don't care if they lose some minutes. But when I'm there for a pediatric patient and anesthesiologist is taking 4 months to interview the mother and then a whole bunch of time to start an IV, I'm just sitting there. What's happening? This is, shouldn't they cover that?
Yeah, that's a real problem because you don't get paid for waiting. So if there's not, you're there in the facility, there's really nothing else you can do. Maybe you can answer emails or respond to patient phone calls, but you're completely stuck. The minutes that you get paid for your pre and post-op time is only the actual minutes you're spending with the patient. So, as a cataract surgeon, I worked in a multi-specialty facility that had lousy turnaround time where, you know, it was 20 minutes in between cases. But if I went to an ASC that was just cataract, it was like a 5-minute turnaround time. So you guys are really hurt by that. And it gets to the point where it becomes more financially viable to see patients in the office than it does to do surgery. And I think that's a real threat to access to care, especially with the increasing E&M payments. You can probably do more RVUs, dollars per hour, in the office than you can with a complicated OR case.
Yeah, the one thing, if I could say, there is some payment for talking to the patient or family both before and after the surgery, called the pre-service and the immediate post-service. Its dollars per minute are, of course, lower, but there is a lot of time in the Strabismus codes for reviewing the information beforehand, as well as prepping the patient to go out the door. But the problem is, Eric, you aren't paid for all the time you sit there wasting.
Yeah, that's exactly right.
And then the PLI factors into that, but it truly is a fraction of a percentage. It's what, 4% of payment.
All right. So I'm going to remind everyone to try and use the Q&A function, but I'm over in the chat now. Jennifer asks, do you believe that this fee change, even if phased in, will be stable for 5 years or 10 years? So David, that's a great question about what's the lifespan of a value. Can it ever go down? Can it ever go up?
Yeah, so it depends on the code. So cataract, which gets done 1.7 million times a year in Medicare, is constantly being looked at and will be reviewed again in a couple of years. These codes weren't looked at for 30 years because the volume in Medicare is so low, and they probably won't be looked at again in another 30 years. The issue of can they go up versus can they go down, it's almost a one-way valve. It's very hard to get an increase in value for something unless there's a fundamental change in the way the surgery is performed, which requires, you know, increased intensity or increased time to do the same thing. And that rarely happens. Usually as the science and art advance, things get faster and easier, and we get rewarded by being paid less for that.
David, there's a follow-up question on why is the waiting time not addressed at the RUC level? And I think there's no good way to do that.
Right, the RUC, well, it's not just the RUC. CMS is not going to pay for waiting time. They just won't. It's just their policy.
All right, so now we're going to get to the nitty-gritty. Eric asks about the reference survey, and his comment is, why in the reference survey did we have a bunch of low values, lower than the actual current RVUs? And I'll start by saying the survey had to cover the 11 code range. And so OCT was down there as a floor. The RUC insists that we have values that span the range. I unfortunately don't have a whole survey in front of me, but I know it went above the current values. But we have to span a range, and we had to do the single instrument for all the codes, and they had to be RUC surveyed in the last 5 years, preferably. So the space, the constellation for developing these surveys is very difficult for the comparisons. But we'll have to take the question of the RUC survey offline, Eric, and we can do that subsequently so that I can look at the top value. Kayla might be able to pull it live and see if she can find it. There's a question about, maybe this is an observation, what would happen if all people working in the OR would be salary and not hourly paid? Would it change productivity of the staff? And I guess that's a leading question. The assumption is yes, it would, because most ASCs seem to work on get the day done and get home. And most hospitals don't work that way. but you'd have to implement it and find out. Christy asks, and we asked this too, by the way, in our 2018 letter, why do you care about these procedures when the volume is so low? Why, therefore, this strabismus is a rounding error for CMS on the pro fee side, as well as on the facility side.
Yeah. I can address that.
Yeah, go ahead.
So this is really tragic. I mean, I mentioned that in 1998, they adjusted the value of the add-on codes downward because they were being paid for 4 post-op visits when their base codes were also being paid for 4 post-op visits. So they hacked a few RVUs off of them, but they didn't do it in a sort of RUC acceptable way. And a clerical error occurred in which the post-op visits were still included, even though there were no work RVUs associated with them. They were still getting paid some PE RVUs. So because of that, they were noticed again with a screen for add-on codes that still had post-op visit payments associated with them, which there shouldn't be any. So if it hadn't been for that, they probably would have been ignored all along if they had completely taken the post-ops out in 1998. So, we went to the RUC and we said, and this is part of our sort of kicking the can down the road strategy. We said, look, this was a clerical error. Just back out the values and leave them alone. The volume is so low. This isn't going to make a difference. We don't want to revalue the whole family. And they looked at the codes and they said, well, they've never been surveyed. There are still Harvard valued dating back to 1992. We can't live with that. There's a significant volume in Medicaid, which is, part of a government system as well. So you have to value them. And that's the sad story of how it got caught in the trap of having to be revalued. And I can comment also on the reference service list. Actually, there were 2 reference service lists. There was one for the add-ons and one for the 90 days. And I believe the top value for the 90-day codes was 12.13 of vitrectomy. So it did span the range pretty well. The ZZZ, the add-on codes, of course, they had lower RVUs going all the way down to that 0.4 RVUs, but all the way up to 5 RVUs. So they did span a range, and they did have to be approved by the RUC.
David, the next question is, I actually need to go back to one from Jennifer, but I want to address this now, which is the PLI, or the professional liability insurance, the smallest component. And it's mentioned on the questions that, of course, it's derived as a value for ophthalmology. In our E&M services, by the way, or in the I codes, it's actually a blend between ophthalmology and optometry. And these are based upon actual charged malpractice premiums, and there's a big formula that the CMS uses for it. But as far as I know, they don't make a big difference for pediatric eye care, for instance. All right, I'm going to guess no response on that.
I think the PLI is something like 5% of the total RVUs. So even if it were double, it still would be a small effect on the actual.
The
total.
average is 4, so even lower.
Okay.
But it does change based upon the service. So there are some things with lower amounts and some things with higher. But again, it's a small component. Jennifer asked, and I forgot to finish this, David. So why could this go down in the future? Why could this get further damaged?
Yeah, so you mean if it got surveyed again? Is that the
question? Well, if it got called in to be surveyed again.
So the worry is, whenever you do these surveys, you can't really tell people much about it other than make sure you answer honestly and don't sell yourself short. And there tends to be a sort of apathy and lack of interest. Not with these codes. Boy, you guys were gangbusters. I've never seen such a good response. But the problem is, if people don't know what the current times are, they don't know what the current work values are, and they've sort of gotten used to the lower values over the past few years. If the survey results come back with lower times or lower work values, then we're stuck with those survey results. Yeah, I kind of doubt that would happen with these codes. First of all, I don't think they're going to come up for review again. But if they did, I suspect they would not go down any further. I think the inter-service times that we got on the survey were probably pretty realistic. I don't do these, but talking to people who do tell me that, 20 to 30 minutes for a single muscle is inter-service time, not all the extra time on the other end of it, is a fairly realistic number.
I would say that, David, on those times, the medians are realistic. We saw amazing ranges on every code, which incidentally we see on every procedure. So there were people competing to be the fastest, and there were people competing to be the slowest. And it's just the times that it took each person. And in the end, the median is probably what we have. Could they ever go up?
Yeah, so I sort of mentioned that before. If to go up, you have to present to the RUC something called compelling evidence that there was a real change in the way the service is being performed, a change in the technology, or that the current valuation is flawed. So, we could try to say that we got a better survey result if we got 200 instead of 50, but the differences in the times and values between the pre-pause and the full data set were not large enough to make a strong argument that the survey was flawed. So I think we'd have a tough time finding compelling evidence.
Well, how about a new technique or a new means of reattaching the muscle might be the way to resurvey? Of course,
Sure.
There's always a risk of going down.
Sure, but unless that new technique requires significantly greater intensity, and remember, we already have intensities that are sort of off the chart for any extraocular procedure on these. So there's not much room to go up on intensity. The only other way it can go up is if the times go up. So if you think that this new technique is going to be adopted, even though it takes a lot longer to do, how often does that happen? I mean, you're going to have substantially better outcomes to want to spend more time in the OR doing it.
Yeah. Christy asks about the risk and the PLI of strabismus surgery, and that obviously an endophthalmitis is a large claim. The problem is it has to affect the premiums paid by the doctor at an appreciable level, and it just isn't going to. If the risk is as low as we think endophthalmitis is after strabismus surgery, it's not going to move the needle, unfortunately. Eric asks, and that's probably the best question for January 1st is, when will Medicaid, state Medicaid, and private pay rates change? And they're all over the map. Some may never notice, some may notice, and it's a year. But typically the commercial companies change on their own schedule. They'll look at these. My assumption, frankly, is they'll see reductions and they'll be pleased to take those into account in their fee schedule, but it won't be on January 1st. I'm sure some of you following the E&M updates or should be following the E&M updates in what's being reimbursed. They're still all over the map in terms of whether E&M pays better than I-coding. All right, now we've got a coding question from Nick. All right, a 67311 in a 3-year-old child is clearly different from a 67311 in a 70-year-old. Do they, or would they take this into consideration?
Short answer is no. The longer answer is all of these procedures are valued for what they consider the quote typical procedure. That means what happens more than 50.01% of the time. When the surveys are sent out, they're sent out with a vignette describing a typical patient. I believe these are mostly children. And the respondents get to answer whether the vignette was typical. And I believe the vast majority of respondents said the vignette was typical, and they valued the procedure based on that. So every code in the book is based on a typical case. And the assumption is there are going to be some that are easier and some that are tougher. There are very few instances where it's different for, at least in I codes, where it's different for a baby. So we've got 66982 versus 66984 for cataract surgery. That's ours. There's hernias in under 5-year-olds versus over 5-year-olds. So that happens sometimes, but the volume of these procedures is not great enough to warrant separate CPT codes for an infant and an adult. We've been debating for a while, goniotomy, which is valued on an infant and actually is being done mostly on adults now by the glaucoma folks. And this is another code where we're trying to keep it under the radar, because if it gets revalued, it's going to get creamed.
Even if we divide it, it'll get creamed. Unfortunately, it also has long times. And not because it's not good work, it's just because of the system we find ourselves in today that's heavily time-based, which is the system. In this set, essentially all of the base codes were done in children, or at least children up to 18. The add-ons for reoperations were done in adults, but there's not a way to get a pediatric modifier. It's been tried before by all of the surgical specialties have banded together and were turned down on that request at least once, if not more, over the last 2 decades. But it is a great question that on the valuation.
The RUC did take into account that the typical patient was a child, and that actually made it much easier for us to get those magnitude estimation of work values, which are much higher than what we would have gotten with crosswalks. So they tend to not give too much grief to those who are taking care of kids. But there still was a lot of grief to be had, and that was just baked into the data, into the survey results.
I thought, David, since there are no open questions, I'd make one comment. Unfortunately, what CMS has done recently, and it's also been discussed, is sometimes they decide to go under the RUC values. Now, we had no expectation they would do that here, but they are more and more doing that. And you'll see those are places where the Academy has an opening to criticize CMS for silly things they do. And they've certainly done it many times, but in the past, but they seem to be increasingly prone to it as the years have gone forward. So Christy asks the bottom line. Well, Dr. Repkin, Dr. Amadeo, and Dr. Glasser have been totally pessimistic or thinking we got the best out of a bad deck. What can we do? And I think first off, writing the note, brief is fine because they're sorted by computer intelligence to see where they're getting comments. And I know that, at least I'm certain, that she submitted her letter on behalf of the association. But there are important things to take to CMS. Now, the next question, would a public campaign ever work? The likelihood here is it would be way too expensive. We can't mount, for instance, we couldn't mount a public campaign on preserving the value of cataract surgery if it was cut. And that affects people that actually are, Medicare beneficiaries who vote. Could there be a legal avenue? One can sue CMS. Kayla, has anybody ever won suing CMS on a work value that they put in the rule?
Not to my knowledge.
Yeah, it's an extremely expensive kind of maneuver, and usually HHS will win. And of course, we are in a position where we're a specialty of small size and less stature among Medicare beneficiaries. So Christy, you might want to chat and tell us what you think we should do there. All right, well, she'll come back when she can. This is being recorded and will be available to view on the APOS website, as well as the discussion of this similar topic that we did back at the APOS annual meeting is outside of the annual meeting thing. All right, let me go down to Eric, this time Lichtenstein.
Dr. Epka, on the legal portion,
yeah.
Actually, when we were discussing about the globals and maybe pursuing legal action there, some of the pushback was that we couldn't argue legally for a specific value. And that's why a lot of people fail. So apparently there's a law somewhere that prohibits suing for a specific value.
Which does bring up the case that if just this is a totally allied but different subject we haven't discussed, and that is right now in this year, our post-op visits that are bundled into the value, the total value there, are reduced because CMS did not increase them when they increased the E&M codes. And that would, if the battle with CMS over that policy would succeed, then the strabismus surgery codes would get a small lift. And I know somebody did a calculation on that, but it's not the 22%, but it's a few percent of improvement. Eric Lichtenstein wanted to know, is there a pathway to create a pediatric or amblyopia risk surgical modifier that could serve as basically a multiplier? Cost Medicare nothing if we get paid more for pediatric cases. There wouldn't be a way through CPT that I can think of, Eric, for that. I just can't think of anything that mechanism that would do that other than negotiation with the individual payer. And I agree, it costs Medicare nothing if they change the rates for these cases. For pediatrics, it really doesn't cost them anything if you raise the rates for adults either. There just aren't enough that moves that number. But I can't think of a way to do that other than payer specific, that is going and meeting with UHC or Aetna and saying, you know what, these cuts are egregious, which they certainly are. And this is going to hurt your beneficiaries. And maybe in your UHC products, you could help us there by boosting them. So I'd say it's worth at least exploring the commercial pathway. I think the Medicaid pathway, you might as well fold your cards. And Christy just reaffirmed that the APOS has submitted an organizational response. In that response, David and I and Steve Krug from AAP helped with some things like arguing for the higher rates for the base codes based on not following RUC rules, but doing it sort of because it was easier for people to do the survey. APOS has submitted that response, and I'm sure Christy or I, if you wanted to call, we could talk about it and see whether that was something that you could put into a letter. That would be great. Eric, absolutely, the savings to CMS are redistributed, so they actually don't even save the money. It's just moved to other codes within the total CMS budget. So but the dollars, as we said, are rounding errors. They just aren't very much. All right. Oh, Mark Preslin asks, and this is a great question. And this one really, I'll have to drive to Kayla since her job is to support advocacy. Why write to CMS since we've presented this as appearing futile?
There's never a downside. I see that question there. There's never a downside in voicing your public opinion. You absolutely want to be a part of the public comment process because we want that process to continue. We want to always be able to have input, regardless of if we feel like it's futile or not. But there are some, and I think Christy has laid this out. There are some avenues there's some steps that CMS could take. I know we didn't dive into the globals issue, but global payment equity would help a little bit if CMS applied that, and they certainly could. So raising your voice about how these cuts are going to impact you and impact your patients are extremely important. And we will cross our fingers and hope that CMS takes them into account, but it's certainly better than not saying anything at all, because it's the squeaky wheel gets the the oil or whatever.
Yeah. All right, so the 3 words you need on that comment are global payment equity. The other thing that we actually have argued in our own comments to CMS and to OMB before was the impact of these cuts would have on diversity and equity in healthcare. And that actually is the other comment that I would stress if you could add those other key words. We certainly are in our previous comments, in our presentation to OMB, and now in response, that these are too big a reduction and will hurt access. Kathy Lee wants to do the calculation of the impact. And so the only way to do that is for somebody to say, take a rough percentage, maybe 10% or 15% against their surgical dollars and do a multiplier or a decrement there. And then, of course, maybe you offset that with a little bit more care on E&M coding to try and get what the impact will be. But the impact is, of course, going to depend on how big a surgical volume somebody has versus an office volume. And our practices, are typically, you've seen one, because we're just all very, very different. Let's see. Nanos did support APOS and is submitting a response in opposition. They did help us survey, that is, they surveyed along with APOS, and they are also not a RUC member, so they will be opposing as an organization. Christy wants a meeting with the administrator of CMS. I assuming you don't want a meeting with the head of HHS. So how easy is it to get? They're almost impossible. But Christy, there's never a reason you can't try. There are routes that you can do. Certainly we can try, but even your senator might be able to get you a meeting. So in many ways faster than the professional organizations can. Was that, David, that wasn't too cynical, was it?
No, I mean, it's a big ask, but you never know. If you get somebody interested who can put in a word for you, you might be able to get a meeting.
Yeah. Whether you can get to Barakal at the moment, I don't know. That's they've got so much going on. The last year has been pandemic all the time at HHS.
I will say, before you go on to the next question, one of the things that we're going to put in our comments is asking, even though we can't ask for more than the RUC recommendation, we can ask that the cuts be spread out over a longer period of time. So, if there's a 21% cut coming, spread it out over 3 years equally instead of 19% and then 3%. That's something that you might consider asking. Whatever they come up with, spread it out so it doesn't hurt as much all up front.
Okay. And Kayla just put into the chat, so she's going to read. We actually did do a calculation as part of our appeals process for what the savings would be or what the transfer of revenue would be. So in Medicare, Kayla, it looks like we've got 2.7 million is all that's being reduced in Medicare, or is that in Medicaid?
That one's Medicaid. Medicare is 23,000.
Yeah, I mean, we are talking, as you guys have mentioned, trivial amounts of money in the healthcare budget. And I do want to go back to the global payment equity since there's some uncertainty about what that is. So again, this is important. It's ongoing across all surgery. It's something that the Academy has spent almost $1 million on a public policy campaign to restore the equity of the level 3 or level 2 or level 4 visits that are bundled in the surgical payment. Right now, they did not boost them with the updates that everybody else got when they do them in the office for 2021 and are going to get in other settings this coming year. So that would move some dollars back to the surgery for the post-op care. And people always forget that you bundle them, but there's actually a payment built into the surgical fee. And the number of post-op visits and the level of post-op visits is a survey outcome. The survey data are what rule that.
Yeah, we've run some numbers, and the EMA has run some numbers, and if they actually paid post-op visits that are bundled into these global 10-day and 90-day codes at the same level as they're paying E&M visits, for ophthalmology, it would mean an increase in something like 4 to 6% increased payments across the board. Obviously, it'll affect people doing a lot of surgery with a lot of post-op visits more, but it's a substantial amount of money. And it's something that we feel is just an inequity to be paid less for the same exact work.
Yeah. So now, in a way, we've had the futile question. Now we're going to have the acceptance question. Maybe some phases of depression. So Steve is asking for a longer phase in an implied acceptance of the reduction. I suppose what you do is you put it in the second phrase, but if you're still going to go and implement this, couldn't you make it so the practice delayed or slowed down so that the practices can take more time to adapt? But yeah, it's a implied acceptance, but it's in some ways, accepting the truth that they see it. So if you are only going to get one little bend, maybe that's the place that it would be better.
From my perspective, asking for maintaining the values at their current level is probably not a realistic ask. You can ask it, but I don't think it's going to be considered seriously. So asking for a more reasonable reduction than 22% is maybe part one of that statement, and part two of that statement is, spread it out, just like Michael said.
But it's just not good. There's no way.
There's no way it's good. Yeah.
And this is in a way what happens every year to physicians nationwide. And our specialty is not unique. It's in some ways our subspecialty is unique because it's avoided this for the bulk of most everybody in practice's career that could be on this call. And it was, and the impacts on us are great. The impacts on the program are trivial. And that's what makes it feel even more unfair.
Yeah.
So I see, Christy, that I have no further questions in either of the communications portals. So I'm going to turn this back to you so you can explain how the staff are going to put this up as well as the earlier one. I think we could also post the RUC survey list. Is that allowed, Kayla?
Yeah.
Public record.
It is public record.
Since I was only able to stumble without knowing the right numbers, we'll provide that.
I have them for you, but since the RSL is pretty long, we can just provide that.
Okay. All right. Well, thank you, Christy.
She's coming back.
All right. I thought she just
Thank
abandoned
you.
us.
No, thank you, guys. You know, there are lots of unanswered questions. Clearly, it's emotional. It's devastating to us as pediatric ophthalmologists. You know, I'll certainly reach out to my congresswomen and see about meetings. You know, anything we can do to try to mitigate these losses is a good thing. So, you know, we do appreciate the help of the AAP and the AAO, and recognize that it's a bad situation, and, you know, we're trying to do the best we can.
Could I make one closure? Even on those data set, the time data were so much better than I predicted 2 years ago when we started talking about this. So that the members did do them, I think, factually and weren't competing. Because if those times had come in lower than we saw in that table that David presented, we would have been lost even greater depths. So I think we have to thank everybody for filling them out as truthfully as they could.
Yes, I mean, the APOS members really stepped up and they did a great job. And it's good to know that there would be no change in the pre-breach survey data and the post survey data. So I think that's important for the membership to know as well.
Right, but we're also, you know, the whole thing with that during the COVID, you know, the first days and weeks of COVID was just crummy for everybody, and I suppose it helped our survey results, but it doesn't make it better. One last question just popped in. Anything the state ophthalmology societies can do, I think they could help on the Medicaid payment side to recognize that reduction here is going to really harm access for children at least in their Medicaid programs. I don't think that there is anything that typically the states will write a comment letter, although I guess occasionally some might. So if your state society is submitting a comment letter, have them submit with the same bullet points that we've talked about here. They'll already be doing the global equity one because that's sort of our bullet point, but no harm in encouraging them just the way everyone else should.
Right, and those bullet points are on the APOS member discussion board. So they're easily retrievable.
Oh, and short is always, I mean, there's no reason or rationale to write a very long plea. Shorter, impassioned with facts is always appreciated.
So thank you, guys. Thank the AAO DC office. Thank you, Dr. Repka, Dr. Amadeo, Dr. Glasser. Thanks so much for your time, expertise, and your availability, that we can reach out to you at any time. So any of the APOS members that come up with questions between now and the end of the comment period, mid-September, please let me know and we can pass them on and they'll be taken care of.
Yeah, and I think we're open to a conversation as long as it's you know, reasonable and not with a large number. There's no good way to have a conversation with a large number of people. This is probably the best format we have.
Yep. Okay. Well, so good night, everyone. Thank you, guys.
You're welcome. Good night.
Thanks for organizing
Good
this.
night.
Good night.
Bye. Stay safe.